So let's talk about managing anticoagulation and thrombosis remotely. We're going to use a case-based approach. Case number 5 is regarding frequency of INR monitoring. And this is a 57-year-old female with a mechanical mitral valve that's been implanted 6 months ago on warfarin. She's also taking low-dose ASA, which is often recommended in mitral valve disease. She has INR testing done every 2 to 3 weeks, and she's got excellent INR control with her TTR being greater than 70%. She's a little nervous about attending the lab and wants to know, can the frequency of INR testing be safely reduced? Lana, can I turn this one over to you?
Thank you, Alan. Next slide, please. Thank you. So these are slides that are courtesy of Dr. Shiva Kumar, and these were presented in the 2 previous Thrombosis Canada webinars. So I will review them again here, and we can talk about questions after as well. Next slide, please. So what do you do with patients that are on warfarin and they do require INR monitoring? Now, the patient in our case is quite stable with greater than 70% time in therapeutic range, which is quite excellent, in fact. And many patients are worried about leaving their homes to go and get blood testing done. And so what we do ask is that people consider stretching out the frequency of how often INRs need to be done. So if your patient is going monthly and their INRs have been in the correct range, then it's very reasonable to extend that as long as you are considering what the bleeding risks are and what the thrombotic risks are. And again, that goes back to the reason why your patient is on warfarin. So are they on it for a very recent blood clot in their leg, or are they on it because they have a mechanical valve, for example? Those are things that you need to consider when we are looking at stretching out the frequency of INR monitoring. What we do know from a lot of the studies, such as the PAUSE study that Dr. Duquetis led, is that when we interrupt warfarin for short periods of time or direct oral anticoagulants for short periods of time, we know that the risk of stroke in those few days is quite low. And so it might be safe to potentially extend our duration of INR monitoring. Next slide, please. So what can we do for our patients? So if your patient is getting monthly INRs, then it may be very reasonable to stretch that out to every 6 weeks or every 8 weeks. And it's also important to look at where they are getting their INRs drawn and what we can do to facilitate stretching that out. And we'll talk about that in a moment. As I mentioned, you do want to consider what is the bleeding risk and what is the thrombotic risk when considering doing less frequent INR monitoring. And so for patients with atrial fibrillation that have a low CHAD65 score of perhaps 0, 1 to 2, then it might be reasonable to stretch out your INR monitoring to every 8 weeks. For patients that have DVT or pulmonary embolism that's diagnosed 3 or more months ago, it's very reasonable to consider stretching out the frequency of INR monitoring. And for some patients that have aortic valves that are relatively new within the last 5 years, for example, their thrombotic risk is a lot lower. And so it may be reasonable to increase the duration between INR monitorings. Next slide, please. So when we talk about where your patients are getting their INR testing done, there are obviously many community labs across Canada as well as labs in hospitals. And many of them have done a great job at trying to promote physical distancing. And they've also scheduled times that patients can pre-book so that they are minimizing exposure to other people also visiting these labs. And so if your patient is able to pre-book, then what they do is show up to the lab facility. They can wait in their car until it's time for them to go in, and they go in and get their blood work, and everything is done in a very calm fashion that's pre-specified with everything in terms of precautions in place to minimize risk of exposure. In Quebec, they have community health centers that have also been utilized to expedite this process. And in our hospital lab, for example, we do have the ability for patients to do this as well. So these are options that might be available to your patients where they can pre-book things and make it easier to reduce that risk of exposure. Next slide, please. Other ways that you can potentially reduce frequency or location of INR monitoring, and if your patient is worried about going to a lab facility. Some pharmacies do carry point of care machines, which are very similar to glucometers that diabetics use. And there's a picture of it there on the bottom right-hand side. And so pharmacies that have this, your patients may be able to go in and have a finger poke with a test strip that monitors their INR, and it's immediately read. And so you have the INR available immediately. And then your pharmacist may be able to provide dosing recommendations as well, or can at least provide you with the INR reading so that you can then carry on with the dosing recommendations. There are also point of care machines that can be purchased by patients, and they are approximately $400 to $500. So it is an investment that the patient does required to make, and many private drug insurance companies are not covering the cost of these devices, so it would be an out-of-pocket expense to the patient. While there is that initial upfront expense, there's also the cost of the test strips, which are similar to the glucometer test strips. They're very expensive at about, these ones are about $10 per strip. So you don't necessarily want a patient that is monitoring their INRs very frequently using this, because it can be quite costly. But if your patient is monitoring every 6 or 8 weeks, then this is a reasonable investment that they may want to continue to investigate with. Next slide, please. So as we talked about earlier, depending on what your patient is taking anticoagulation for, there may be the option of eliminating use of warfarin and the need for INR monitoring by switching to a direct oral anticoagulant. And this would be appropriate for patients that are on warfarin for DVT or pulmonary embolism, or for atrial fibrillation, for example. With the direct oral anticoagulants, there is no need for routine lab monitoring, which makes it a nice alternative to use. And again, we would not advocate using direct oral anticoagulants in the case vignettes that we've talked about where patients have mechanical valves. There are the options that we talked about in our first case of rivaroxaban or apixaban, because they are direct pill forms and they don't require low molecular weight heparin lead-in for use in DVT or PE treatment. And one of the questions that has already come up is whether or not the different provincial programs are now providing coverage for direct oral anticoagulants. And this is certainly a period of ongoing change. And these 3 provinces listed here, with Nova Scotia, Alberta, and British Columbia, are approving use of direct oral anticoagulants if the prescriptions indicate that COVID-19 is the reason for the prescription. There is certainly interest from other provinces, and whether or not these will be approved in the remaining provinces is to be determined, but we will certainly update our website as we get this information. Next slide, please. Other things to consider are that risk of bleeding with direct oral anticoagulants is certainly low, and so that's another reason you may want to consider switching your patient from warfarin to a DOAC. And then how do you follow up with your patient? So given the times of social distancing and physical distancing, where a lot of clinics are closed and we're doing virtual visits or telephone visits, you can certainly continue to call your patient and ask about bleeding concerns with bruising and bleeding. When you switch to a direct oral anticoagulant and even warfarin, you do want to ask about medication adherence and compliance. Are they taking it? And of course, always asking about new drugs that may be prescribed by a specialist, for example, where you're not yet getting the information from that interaction with the patient, and ensuring that if you're starting a direct oral anticoagulant, you're looking for potential drug-to-drug interactions that you need to consider. And what we talked about earlier in the patient that was on warfarin and having some nosebleeds, indications for holding warfarin and when to administer vitamin K, as we talked about with the information available on the Thrombosis Canada website. If your patient has an INR that's less than 10, very reasonable to hold anticoagulation for a few days. And vitamin K doesn't need to be administered if they're not having any bleeding. Next slide, please. Okay, Alan, I'll turn this back to you.
Thanks very much, Lynn. On behalf of Thrombosis Canada, I'd like to thank everyone for attending today's program. I'd like to express thanks also to Dr. Duquetis and Dr. Castellucci for their excellent presentations and answers to your questions. I also would like to thank our sponsor, Bear Canada, for their unrestricted grant for this program. And be sure to visit our website regularly and often, as we add new materials all the time and are always updating our clinical guides and tools. So with that, I wish you all a safe afternoon and safety throughout the rest of COVID. Bye-bye now.